Seat up here. Welcome everybody. My name is Denise Gibson. I'm the program director here at Town Square University Parkway. It's nice to see so many faces that are familiar. I want to introduce Catherine McDermott. She is a board certified in both primary care and psychiatry. She attended St. Joseph College in Connecticut for her Bachelor of Science in Nursing and attended Yale University for her master's degree as an adult nurse practitioner. She received her postmaster certification from the University of Cincinnati as a psychiatric mental health nurse practitioner. She has specialized in geriatrics and cognitive impairments for the last 15 years. She has been in nursing for over 32 years. She is the co-owner of Gulfside Behavioral Care, a mobile psychiatric practice that serves patients in assisted living facilities, and is the co-owner and fearless leader of us here at Town Square University Parkway. So welcome, Catherine.
So for all of you who are at Dr. Cummings' talk, it's always hard to follow Tam because she's such a great speaker, so I'm going to do my best. This is a subject that is very near and dear to my heart because, as Dr. Cummings mentioned, I think in general there's a lot of myths and a lot of misunderstanding about medications that we use for folks that have dementia and cognitive impairment. So I'm going to throw some myths up here and ask you guys to help me say if they're true or not true, and then we're going to take them apart a little bit, okay? All right. So again, the whole purpose of this talk is to kind of get you to understand better what the current treatment options are and what we're actually treating in dementia. So as Dr. Cummings very adeptly spoke, dementia is a brain disease. It is a neurologic condition. It has a trajectory of one direction. Now, in the different dementias that Dr. Cummings went through, there are fluctuations. So you may have a period of time where your loved one with dementia does well, and then they sort of drop off again. Or you may have one of the types of dementias where it's just a progressive, slow decline, and you don't really see that. And there are symptoms that go along with that that we can treat to help the person with dementia. So the first thing we're going to talk about is, first myth, there are no medications for the treatment of dementia. Is that true or false? False. That's right, it is false. And recently, there have been new medications that have now hit the market. Now I know there's a lot of information on this slide, and Dr. Cummings told me there was too much information on this slide, but I just want to briefly touch on these. So these new medications that have come out are basically in order to try to prevent the person from declining with dementia. Again, it significantly slows the disease. Doesn't mean it's going to cure it. It just means it's going to significantly delay it. And so what we're looking at is we know that in the brain, these beta amyloid plaques begin to develop. And what this medication does is it reduces those plaques from forming in the brain, thereby improving cognition. Now, with every drug that's out there, people will say to me, oh, I went to the pharmacy, I got this medication, I went home and I read the side effects and I don't want to take this medicine, this is terrible. Well, if we read the side effects for Tylenol, we would realize that one of the risks is liver failure. But we all take Tylenol without even really giving that a thought. These drugs are new. They have made it through the FDA. Some of them, the clinical research was a little, what can I say? They got through. But the studies were small, and there are significant risks to these medications. And they're not a medicine that you just get a prescription from your doctor and go to the pharmacy and get it filled and it's a pill you take. These medications are administered by IV. They can cause brain bleeds and seizures, which can be very significant. So the jury is still out for a lot of these medications because they're not readily available. We don't have a lot of people that have been able to utilize these medications, and we don't have long-term studies yet, but they are extremely promising. So perhaps not for your loved one, but for your family and your loved one's children and so forth, these are going to become really important medications. The other issue is, and we all know this, when a drug has to go through clinical trials and research and development, it is extremely expensive. And so these medications are in the tens of thousands of dollars in order to complete a year's worth of therapy. Now, Medicare has approved them, and there are some Medicare, straight Medicare will pay for it, but the Medicare Advantage plans have not quite gotten on board yet. Okay? All right. I'm not going to go into all of this science, it's a little bit much. Okay. Okay. Then there's the dementia medications that we all are familiar with. How many of you are familiar with these medications? They look familiar? Okay. So Aricept, Exelon, and Razidine are called anticholinesterase inhibitors. Again, has to do with neurotransmitters in our brain, has to do with slowing down the progress of the disease. Namenda is an NMDA, again, chemical drug that helps slow down the process of dementia.
Thank you.
Typically, when you're mild to moderate, you'll get started on Aricept, otherwise known as donepezil, Exelon, otherwise known as rivastigmine, Razidine, otherwise known as galantamine. And people will come in and they'll say to me, I've been on this medication, I'm not getting any better. Because the medication isn't meant to make you better. The medication is meant to hold you where you're at, even though we know the decline is going to happen, it's not going to happen as quickly. Am I boring you, Teddy? The Namenda is more for moderate to severe dementia. And we find that when we put them together, they work better together. So the pharmaceutical companies have now actually come out with a medication called Nemzaric, which is a combination of the Namenda and the donepezil. So you can take it all in one pill. So, and part of that is, and again, money makes the world go round. So when a drug loses its patent, it can become generic. So donepezil is a generic medication now, as is Namenda. When it became Nemzaric, it got a new patent. So then it became a proprietary drug and it could be sold under the brand name and insurance companies would pay for it again. So there's positives and negatives to all of these things, but we do know that even if you're just taking Aricept and Namenda, you're going to have a better effect than if you take one med without the other. One of the other things I caution a lot of my patients about, the ones that come in and say, well, I've been taking this medication and it isn't helping, or, you know, my family member's been taking this medication and it's not doing anything. What I caution them about is that it's one of those medications that you don't know how much it's doing until you stop it. When you stop it, if you have a rapid decline and you restart it, you're not going to gain that ground back. So you have to be very careful when you started on this medication to not basically say, and unfortunately many patients do this, they don't call up their healthcare provider and say, hey, I don't think this is working for me. They self-discontinue the medication. And then they find that they have a significant decline. More often it's their family members who notice the significant decline. So there are side effects to these medications. They're relatively mild. Most of them are GI distress. So some people will have, you know, most elderly folks, because of their mobility issues, already suffer with constipation. It's a fairly common symptom that we see for the elderly. This may cause you to have some loose bowels, but it's usually short-lived and your body gets used to the medication and it doesn't progress. So relatively safe medication that if stopped abruptly can significantly cause decline. Now there are some times where we stop it and we don't see any difference at all. But the problem is I don't have a crystal ball and I can't tell you how you're going to react or how your loved one's going to react if they stop the medication. Does that make sense? Factor myth. Depression and anxiety symptoms are extremely common in dementia and mild cognitive impairment. As a result of these symptoms, many people with dementia experience a decrease in their quality of life. Yeah. Correct. Yeah. Right. So what are the symptoms of dementia that are treatable? So I've listed them here, and I think most of them, again, based on Dr. Cummings' talk, are fairly evident, right? It's fairly common to develop depression when you're living with a cognitive issue, when you can't remember things, when you feel like your functionality, your independence is going away. You can't drive anymore. Sometimes you can't work anymore. Sometimes you can't be that partner to your spouse that you've been in the past. Depression, clinical depression, is not I'm sad about something. Clinical depression is where you've had some form of stressor for a long period of time, and it's affected how your brain uses the neurotransmitters that we have that make us happy. Serotonin, norepinephrine, dopamine, these are all chemicals that make us happy. When we're younger and we're feeling kind of blah, we think, oh, I'll go for a run. And our body raises our own natural neurotransmitters. We have a piece of chocolate. We feel pretty good for about a half an hour. And then all that serotonin runs out of our brain. So when you talk about depression, it's not situationally sad. I lost my job, I'm sad for a little while, but I'm going to bounce back and get a new job and I'm fine. Depression, and the way you can really screen yourself and your loved one for the depression is using the screening tools that are in the back of Dr. Cummings' book. But a lot of times we sit and we screen a family member and we ask them questions like, are you hopeless? Do you feel helpless? Do you feel happy most of the time? Questions about sleep, questions about appetite. And when we score it out, a lot of times the families are very surprised that their mom or dad or husband or wife scores so high on these tools, because long-term exposure to stress can cause clinical depression. Anxiety, number one common side effect of dementia. People feel anxious when they don't understand something. If I walked up to you, Lance, and I started talking to you in a foreign language, and I was in your face, I wanted to take your clothes off to give you a shower, and you didn't understand anything I was saying, what would your reaction be? I'm sorry, maybe that wasn't a good example. But that's what I often get in the assisted living facilities that I work in, is, you know, they sit one of the residents down and they put food in front of them and they don't pick up the fork or feed themselves because they don't know to do that any longer. But they're hungry. And so they get anxious because they can't do this simple task. A lot of times, I have one member here who, the husband says, I sent her into the bathroom to take a shower and she turns the water on and she comes out and I know she hasn't taken a shower. Well, as my friend Dr. Cummings will tell you, there's how many steps to taking a shower, Kim?
48.
48 steps to taking a shower. Who really thought about that? It's not just grab a towel and jump in the shower. There's a lot that goes along with doing these things. And when you don't know how to do something, when you can't initiate a task that used to come so easily to you, you feel anxious. I tell people, I drive my car every day. I get in it, I don't even think about it. I got 100 things on my mind, I'm doing 100 different things, and I'm driving my car. But when I travel and I get into a rental car, I feel anxious. Where's the windshield wipers? How do I put this thing in gear? Does it have a key or a push button? It's different, and it makes me feel very anxious. That's the way people with dementia live every single day of their life. That doesn't feel good. And that creates a lot of stress. That stress creates the negative hormone cortisol, which burns out those receptors in our brain, and we wind up depressed. Make sense? Yeah. Okay. Agitation. To my point before, one of the things that Dr. Cummings and I hear on a regular basis when we go into the facilities is, this person's agitated. I'm trying to help them take a shower. I'm trying to change them. They've soiled their pants, and I need to help them change. And they're hitting my hand away, and they're, swinging at me, and, why? Well, to that point, people don't particularly, if they don't understand what you're doing, they're not too happy when you walk up to them and start trying to disrobe them. And you can tell them what you're doing, but they can't process that information anymore, right? Auditory and visual cues are very difficult. So sometimes we have to use a combination of both. Well, I don't think that Dr. Cummings got to the point about vision and how their vision is so changed during dementia. They don't see their peripheral vision. They see very much right in front of them. So if you come up along the side of them and want to help them take their jacket off, you're going to startle them. And they're going to get agitated. And they're likely going to take a swing at you if they feel threatened. And so how we approach patients with dementia is very important. We have to take all of those things into effect. We oftentimes have to be very careful in our approach and very purposeful in our approach and use different ways to get across to them what we want them to do. It's not enough to say, pick up your fork and eat. Because if they knew how to do that, they would have already done that. Sometimes you have to pick up the fork yourself and show them. And then they start eating. It was one of the reasons COVID was so devastating for people with dementia, because when you look across the table and somebody else is eating, you pick up your fork and you start eating. And you mirror what that person is doing. Same thing with drinking. People got very, very dehydrated. Because if you're sitting across a table and you see somebody pick up their drink, you pick up your drink. But if you're socially isolated and you're eating in your room all by yourself, you don't have anybody to mirror. And so those things don't happen. Right? Okay. Hallucinations. So this is an interesting one. And again, because Dr. Cummings talked about the different types of dementias and how folks with different types of dementias will have hallucinations, and because people have mixed dementia. So you might have your family member diagnosed with dementia of the Alzheimer's type, which we don't typically see hallucinations in, but there may also be an underlying Lewy body dementia or Parkinson's dementia, in which case hallucinations are very prominent. Hallucinations can be something that we treat or something that we don't treat, depending on what the hallucination is. So I go in and I see a patient, and she says, oh, did you see the parade this morning? And I'm like, no, I didn't see the parade. Oh, yes, it was a beautiful, colorful parade. It goes by every morning at 10 o'clock. And I say, isn't that wonderful? Did you enjoy the parade? And she says, yes. And I go, this lady doesn't need any medication at all. She's very happy with her hallucination. It doesn't cause her any distress. She's living in a fun world. My grandchildren came to visit. I saw them today. They were playing with the vase on the table, which made me very nervous. Okay, they're her grandchildren. She's very happy that she saw her grandchildren. Now, if she says, I saw my dead husband, and he was having sex with my best friend, that's a hallucination that's not a really good hallucination. If you see rats, spiders, bugs picking at your skin, that's not a good hallucination. And we don't want to leave people feeling that way. And I think that that's the most important piece that we need to talk about and we need to take away when we talk to families about medication. And when you, as families, begin to think about medications to treat your loved one. Okay? Irritability. I mean, it just goes along with all of those things. So the one other thing I want to say about irritability is that very much like when we were raising our children and that baby cried, we had to figure out why that baby was crying, right? They didn't say, I'm hungry, I'm cold. Well, one of the things that dementia patients can't tell us is that they're in pain. They can't articulate that something hurts. But when I'm in pain, I am very irritable. I just put it right out there, right? If something hurts, if I have a headache, if I stubbed my toe, everything feels like it's 1,000 times bigger than it is. And I can be very snappy with people because I'm in pain. Well, the same thing happens to folks that have cognitive impairment and dementia. They cannot articulate what they're feeling. They don't, and a lot of times they don't know that they're cold. They don't know that they're hungry. They don't really know that they're in pain. They just know that they're irritable. And so we have to think about that, right? Our CTE folks who have been beaten up their whole life as football players or boxers or soccer players, whatever they did, that got them CTE, their bodies hurt. I get out of bed in the morning and go, ugh. And I'm a lot younger than these folks. So you talk about arthritis pain, generalized muscle pain. As Dr. Cummings mentioned, they lose weight because their muscle begins to waste. How many of you have had a tetanus shot and your arm hurt for a week? That's the muscle pain they feel throughout their body as they get into late stage dementia. Of course they hurt. And I have nurses say to me, well, I asked her if she was in pain and she said no. Did you ask her where she was? Because she didn't know that either. So it doesn't really matter if you ask them. You have to look at your family member. You have to understand what they're going through. You have to understand their history. And you have to predict for them, just like you feed them 3 meals a day, that they're going to be uncomfortable. And that's going to lead to the irritability. All right, fact or myth? There are no safe, appropriate medications that can help with the symptoms of dementia. False. Right. But unfortunately, in our society, a lot of myths out there, a lot of false information about these medications. Okay, so let's talk about the types of medications that we can use. Now, the first thing I want to start with is the folks that have dementia in this generation now were not the people who said, gee, I'm feeling sad, I'll call the psychiatrist and make an appointment and go in and get medication, right? That's not what they did. Half the time they didn't even recognize that what they were feeling was depression or anxiety. And they would self-medicate. They would drink. They would overeat. They would use whatever their drug of choice was to make themselves feel better. But they didn't necessarily use the correct medication. So in the late 60s, early 70s, medications came out called SSRIs, which were selective serotonin reuptake inhibitors. And they changed the face of psychiatry in treating depression. How many of you remember when Prozac first came out? Right? Prozac was an amazing drug. And it treated your classic depression. And people began to feel so much better. The problem with Prozac when it came out was people treated depression as a chronic illness. So I'm just going to throw this out there, right? You get an infection, right? You get a urinary tract infection and your doctor puts you on an antibiotic. You don't stay on that antibiotic for the rest of your life, do you? So the infection's gone. Somehow, the sort of prevalence is that if you get depressed and you go on an antidepressant, you're on it for the rest of your life. But that's not the way it's supposed to be used. Depression is something that can be treated and can be cured. So typically what you do with somebody when they come in the world of psychiatry, and this isn't always what happens in primary care, which is part of my sort of bias that you should see a psychiatric provider when you have a psychiatric problem. And all due respect to my primary care friends. But, you know, just like I don't treat hypertension, I only treat psychiatry, and I do it for a reason. But if somebody comes in and they endorse for depression, they have all of the clinical signs of depression, and I say to them, okay, we're going to put you on this medication. It's going to take 2 to 4 weeks before you're going to start to feel better. They come back in 4 weeks, and they're like, yeah, I'm starting to feel better. By 6 weeks, they're right back to their functioning self, their mood is good, they're sleeping better, their appetite's good, they're feeling like they can go out and socialize again. I say, okay, I'll see you back in 3 months. They come back in 3 months and they're still doing really well. Now they've had some setbacks, they lost another job or their girlfriend broke up with them or whatever. But yet their mood has managed to stay and they're doing well. We very often in times in psychiatry will recommend psychotherapy as well. Figure out what it was that sent you spiraling down into this depression. Do some work on yourself, whatever's been going on, start to feel better. They come back in 6 months, and if they're still feeling well, they are considered cured of their depression. And then you begin to taper them off that medication. Many folks go off of the medication, and they stay off of it for years. Years and years and years, and they do perfectly fine. And then maybe some other life event happens, and they find themselves depressed again. Well, if they come back in and see you again 5 years later, You may choose a different antidepressant, whichever one is most appropriate for the type of depression that they're complaining of. But now you're going to leave them on twice as long. So if they achieved remission in 6 months, now we're going to leave them on for a year. At that point, if they're better in a year, do the same thing, taper them off the medication. Now, if you come back to me again and you're depressed, now you've bought yourself lifetime. But it should not be the first time you go on that medication. And, the kind of prevailing thought is, well, I'm feeling better on the antidepressant. If I come off the antidepressant, I'm not going to feel well. And that's not necessarily true if it's only the first time that you've been treated for depression. Now, everything I just told you, we're going to throw out the window when it comes to geriatrics. Geriatric depression is lifetime. Because you're in the autumn and winter of your life, your brain doesn't have the ability to regenerate those neurotransmitter receptors in your brain. And so when you go on the antidepressant, it's going to be for the rest of your life. Does that make sense? Yeah. Antidepressants and anti-anxieties medications are typically now what we call the selective serotonin reuptake inhibitors. There's norepinephrine reuptake inhibitors, and these are all the different neurotransmitters in our brain. We have ones that affect dopamine, which is our pleasure and our happy chemical as well. And now there's selective serotonin modulators that are coming out. So there's more and more new antidepressants that are coming out that if you failed one, there's going to be a medication that eventually is going to help you. Now we do have some people who have treatment-resistant depression, and we have a very hard time getting their mood back up. But the majority of folks can be treated with these medications and brought into remission fairly quickly, or in the elderly, put on these medications and their mood and their anxiety will be helped. So the antidepressants, even though we call them antidepressants, we also use them for anxiety, because all of those neurotransmitters are the same neurotransmitters that affect our mood, both as anxiety and as depression. One of the big things that I have a problem with as well is when people get put on medications like Ativan, Xanax, and Valium. All you guys familiar with those medications? Okay. These are anti-anxiety medications, purely. They're called benzodiazepines, and they raise GABA in our brain, and GABA makes us feel fabulous. When you take a Xanax, you get a little bit of a high from Xanax. You feel like you can conquer the world. So it has a very high abuse potential. What happens after you've been taking Xanax for a long time is you begin to lose the effect of the anti-anxiety, but the sedating effect is still there. So it may make you a little sleepy. Xanax is meant for rescue. So your house burns down and you're a disaster, and you call your primary care and they give you a week's worth of Xanax. You lose your job. You are in a hurricane and your house floods and your heart is just pounding out of your chest, and you're so anxious you just can't even function. Rescue short term. That's what we use benzodiazepines for. I find people come in and they're on Ativan. They take it every night for sleep. How long have you taken it? 20 years. It increases your risk of falls. It worsens your cognition, and it loses its ability to help you over time. And so you start with 0.5 milligrams, and then you go to 1 milligram, and then the 1 milligram is not working, so now you gotta go to 2 milligrams. And now you've got more side effects. The way to treat anxiety is by using a medication that treats the anxiety and depression from below. Not from above, where we're just gonna cover it up and make it feel better for a couple of days. We need to get to the issue, which is the imbalance of neurotransmitters and how we use those neurotransmitters in our brain. And this generation doesn't like to admit they're depressed because they see it as a social stigma that they should be able to pull themselves up by their bootstraps and muscle through. But we don't tell somebody who's got diabetes, hey, don't let your blood sugar be high. You can do this. We don't tell somebody who has thyroid disorder, why do you have that? Why do you feel that way? Why are you letting your thyroid not work for you? But with depression, we forget it's a brain and neurotransmitter issue. The person has no control over the fact that their brain doesn't use those neurotransmitters. And so when we invalidate their feelings by saying, oh, don't feel that way, you got a lot going for you. Well, their brain's not really working for them right now. So it doesn't help, and they actually get worse. Make sense? Okay. In dementia, we oftentimes see patients have what we call mood lability. So 1 minute, they're perfectly fine, they're happy, and the next minute, they're anxious about something. And then not even 5 minutes later, they're angry. Like, I didn't even do anything, and now they're yelling at me. And then 5 minutes later, they're happy and they're laughing again. And it's like a roller coaster. You're like, I don't know which mom I'm gonna get today. Is it gonna be Mary Poppins or gonna be Cruella de Vil? I just don't know what I'm getting. And that up and down, which makes us as caregivers very uncomfortable, makes the patient very uncomfortable because they can't control their emotion and they don't know why they're feeling the way they are. Antipsychotics. This is the big one. This is the one that everybody, you write the prescription, they go home, look it up on the internet, Dr. Google, and Dr. Google tells them it's got a big black box warning in dementia. It can cause sudden death and stroke. Your loved one is dying of a terminal illness. If your mother had metastatic breast cancer throughout her body, would you say, oh, I don't want to give her morphine because it's addicting, and right? You would treat her pain. Well, it is painful for the patient with dementia to think they've got rats or bugs crawling all over them. It's painful for them to think that you're trying to hurt them when all you're trying to do is assist them. And so we use the antipsychotics very judiciously, very sparingly, until we see a benefit. Do they have risks to them? Absolutely. But so does Tylenol, right? We have to weigh the risks versus the benefits. And I as a psychiatric provider, and the good psychiatric providers that I know and work with, all talk to the families and explain to them, this is a risk versus benefit. Your family member is, unfortunately, has one trajectory with this disease, they're going downward, and our goal is to make them comfortable for however much time they have left. And so very often these medications need to be used. And there are lots of primary cares that don't want to write these medications because they know the family is going to look at the black box warning. And so what happens is I get folks that come into my communities or even into town square and they say, I begged for somebody to give me some medication to help my mother or my husband or my sister, because they saw how much pain their loved one was in from these hallucinations and delusions. And delusions are very common in all types of dementia. It doesn't matter what kind you get. So the difference between a hallucination and a delusion is, in a hallucination you actually see something, right? You think you see something that's real. A delusion is where you believe something that maybe has a seed of truth in it, but isn't really true. So in other words, you can't find your pocketbook. Now, you don't remember where you put your pocketbook down, but that's not the right answer, right? Because it could possibly be that you couldn't remember where you put your pocketbook down. So somebody stole your pocketbook. Hear that one all the time, right? Well, of course, the cleaning lady came in and took my underwear. Possible, right? Maybe she took it because she was taking it out for the laundry and she's going to bring it back, but you know, that was the last time they saw it. Or a friend comes up to your husband, gives him a big hug, you don't recognize this person, well, now he's having an affair, right? And these delusions can become very prominent, and they can become very troubling for these folks. And I tell people I would have a better chance of convincing Lance here, who's a gentleman, that he's a woman, than I would of getting him to not believe these delusions. That's how firmly they are embedded in these folks. And to Dr. Cummings' point, when you follow them around all day long and tell them all the things that they're not doing right or don't understand, it's irritating to them. So if they believe that these things are true, you can't reason with them. And the more you try to reason with them, the more frustrated they get and the more frustrated you get because you're not getting anywhere with them. This is where the antipsychotics can come into place. And they can significantly bring the temperature down in your home, in your assisted living facility, in your life in general. Because now you've got somebody who doesn't necessarily make the delusions go away, but they're not as prominent. It's not the first thing they tell you every single time you walk in. You know, if you dig a little bit, sometimes you can get them to come up with the same one, right? But they're not as troubled by it. And they can have some comfort and have a little bit of quality of life. Does that make sense? Okay. And then pain medication. Again, this is the one time that I am extremely judicious with folks. If you are irritable because you are in pain, then we need to start pain medication. Now, you don't want to go straight to the morphine, right? Like, you don't treat a headache with morphine, but you start with Tylenol 3 times a day. Motrin has its risks, can increase your risk of stroke in the elderly, so we try not to use non-steroidal anti-inflammatories. But we can use tramadol, which is considered a controlled substance, but isn't quite a narcotic. So, and oftentimes patients will have a lot of relief from their pain, and then they're not agitated anymore because they're not uncomfortable anymore. And so sometimes people come in and think I'm going to want to write an antidepressant or an antipsychotic, and my answer is, have her fingers always looked like this? Because that hurts. How about we start with a little bit of pain medication to help her hands? Maybe she'll sleep better. So, this is always an interesting one. How do I get my loved one treated? So the first thing you do is you have to see your primary care provider. Because there are multiple things that can be going on with you that are treatable. In other words, I mentioned before, thyroid. If you are suffering from hyperthyroidism or hypothyroidism, you can have significant anxiety or depression. If you have an electrolyte imbalance, if your sodium is low, you can have a significant effect with hallucinations and delusions. People get crazy when their electrolytes are imbalanced. When you're dehydrated, your hallucinations can be significant. So don't come to me before you've seen your PCP, because I'm going to turn you right around and I'm going to say, you got to go back to your primary care. You have to get some lab work done. I need to know what your vitamin D is. Vitamin D has now, through evidence-based practice, has been shown to be very significant in our ability to maintain our mood. And most of us aren't out in the sunshine all the time because it's not good for your skin anymore, right? And even if we were, we still don't metabolize it the same way as we get older. People, I remember very, very clearly when I first moved down here to Florida, I was asked to go in and see a resident, I'll call him Mr. Smith. And I said to the staff, what's wrong with Mr. Smith? Well, he won't come out of his room. He's socially isolating. We think he's horribly depressed. Okay, so I went in. Hi, Mr. Smith, how are you? Good. I said, so tell me a little bit about yourself. I said, he wasn't really that upset about being in the assisted living facility. He realized he needed help. And I said to him, so why don't you come out to your meals? He said, I'm exhausted. I said, you don't like any of the activities? I love all the activities. He said, but I can't get out of bed in the morning. So I called his primary care provider and I said, can we get some labs on Mr. Smith? His vitamin D was 18. We got Mr. Smith some vitamin D. His level came up. His crippling fatigue went away. He didn't need an antidepressant. He needed somebody to look at the whole person and recognize that there are other medical issues that can impact how you feel. Same thing with hypothyroidism. If you're hypothyroid, you're sluggish. You can barely get out of your own way. If you're hyperthyroid, and I've seen this happen too, where, well, I haven't gone back to see the doctor, they just keep refilling my medicine, but I'm an anxious mess, I'm shaking, I'm losing weight. You have all the signs of hyperthyroidism, Well, your dose needs to be adjusted. You need to have your labs done. Sometimes if you're taking too much medication, it can cause this problem. And then there's the issue of other medications that we take and how some of those medications interact with other medications, and they can also make us feel depressed and anxious. So we have to look at all of it. We have to look at what your current medical diagnoses are. We call those your comorbidities, right? We need to look at the medicines that you're taking, and we need to look at your labs. So don't come see me until you've explored all of that, okay? And then, as I said before, you want to follow up with a geriatric psychiatric provider. This is a very specialized area. I can't do what the cardiologists do. I call my best friend Kate when I can't figure out a medical issue and say, what's wrong with this patient? Because she's a primary care nurse practitioner. But when it comes to psychiatry, a lot of times patients come to me and they're just on the wrong medications because it was easier just to talk to the primary care provider and they put them on a medication and they didn't get any better. And I understand it. There are not a lot of geriatric psych providers down here in Florida, surprisingly, given the population that we have. But if you have the opportunity and you go onto your insurance and you look in your network and you find that there's a psychiatric provider, if what you're dealing with is a psychiatric issue, you should see a psychiatric provider. Same thing for your family members that are cognitively impaired. I cannot tell you how many times families come in and say, I went to the neurologist, I got the diagnosis, and they said, come back in 6 months, and there was no resources, there was no information, there was no how do I treat any of these things. And I left feeling defeated and deflated and not knowing where to go from here. That's the difference with dealing with people who take care of patients with dementia, because we provide a person-centered approach. We look at the whole person and try to help you with those resources, as well as helping you understand the disease process. Does that make sense? How am I doing? All right, so in summary, there's no reason to suffer from the symptoms of dementia, just none. There are safe and effective medications to help treat the depression, anxiety, agitation, and hallucinations that can occur. So I'm going to say thank you, and I'm going to let you know that I'm going to step next door into the library because the next presenter is going to come in and set up, but I'll be glad to answer any questions that you have in the library.